Hello everyone, and this is Douglas Hiscock. This is our work for Silvercloud Health, and I'm the product manager. Thank you all for attending this webinar today, and it's the third webinar. And we're trying to do it with video as well, which is kind of a bit awkward. So hopefully you can see us as well. Today is quite exciting because I've got Dr. Jorge Palacios, who is our clinical researcher. And we're going to be talking about some of the data that we see behind the program, which is very exciting. And hopefully throughout this will get you interested in what we're talking about. And if there are any, and obviously with a webinar, it's quite difficult to ask questions. So if you could please, whilst we talk for about 20 to 25 minutes, and then if you could please put questions into the question part of the webinar box, and I'll have a look at them as we go along. And at the end, I'll read some out for you. So with a great bit of excitement, and I'd like to hand over to Jorge, who is going to talk to some of the myths that we've got.
Yeah. So thanks, Doug, and thanks everyone for joining us. I'd have to say great timing that it was the first day, and it seems like forever that there's no World Cup football on, so we can kind of focus on this for a bit. Hopefully there will be questions. Hopefully more people will be joining as we go along. But the aim of this talk today in this chat is like the title says, to debunk some myths around digital therapy. So to get right on it, I want to use as an example this data set that we have from an exemplar IAP service that has been using Silvercloud for a few years now. And at step 2, they're using it together with guided self-help and well-being group therapy. And this is great because that's what data does in the end. Data allows us to answer questions and debunk myths at the same time. And so that's what we're going to do with this sample data set, which is basically composed of, well, almost 5,000 people across a 2-year period. This is real world data. These are people who went through the programs over a 2-year period, ending in July of last year. And as you can see, the demographics are quite similar to any IAP service. The mean age is around 37, with 49% under 35 and only about 5% over 65. About 2/3 are female. About 4/5 are of white British ethnicity. 69% employed, and overall of these almost 5,000 patients, about half, a bit more than half, were allocated to guided self-help, 40% to ICBT and Silvercloud, so digital online therapy, and 16% to group therapy, well-being. Okay, so that's the data set that you need to keep in mind. So the first myth that we're going to tackle is basically older patients benefit less from online treatments. That's something that I've heard a lot because the myth revolves around the idea that older people do not use the internet that much and don't understand the internet that much. But the fact, and these are general facts, that this age group are the heaviest users of healthcare services and long-term care, and they will grow as a percentage of the overall population between now and 2040 from 15 to 22%. So they'll make up a large percentage of the population. They need to be taken care of. And the internet and computer use is increasing among this age group. So in fact, this may surprise you, but 74% of those between 65 and 74 years old use the internet regularly. Now, just 40% of those over 75 have used it in the last 3 months. However, this will inevitably shift because as these 65 to 74-year-olds grow in age, well, they will have used the internet. So in a few years, it'll be rare to find someone of that age group who hasn't used the internet or who doesn't use it regularly. So the usage is there, But is ICVT helpful for older people? Well, just some general things about ICVT and for this population is that ICVT can help to overcome traditional barriers to treatment and increase access. And this for older people is very important because there's mobility issues there and some stigma issues as well. And there is also studies on low mental health literacy. So ICVT helps with all of this. And also research demonstrates that older adults are more likely to complete treatment compared to their younger counterparts. So that's a positive. So we know they use it, and we know they're more likely to complete the treatment. Clinical trials have indicated that it's acceptable to older adults, and it can result in significant reductions of anxiety and depression, and they're maintained at 12 months. Okay, so all the kind of check boxes are there in place to see, to actually get older people to use ICVT. Now, in terms of IAPT, there's only about 7.5% of older adults access IAPT services in general. However, the recovery rates, and this is IAPT in general, this is not just ICVT, but the recovery rates are higher than the rest of the population. So there's around a 64.7 recovery in those aged 65 and over. Keep this number in mind because this is for IAPT in general, but I'm going to talk to you about ICVT in particular. And this is the source is the IAPT executive summary of last year. These are what some supporters in IAPT have said about older patients using ICVT, and I just highlight that these couple of things for you to keep in mind. That the fact that a lot are retired, they can use the program every day, and that's a key thing in digital therapy, that it is available 24 hours a day, 7 days a week. The other highlighted that they were using the tools regularly between sessions, so they weren't just using it on the day of a review, but they were using it regularly. It was actually something that they engaged with quite a bit. Okay, so having all those seeds in place, let's get to the data. So I want you to look closely then at this graph. So remember, this is from the service that I talked to you about, around 5,000 patients, and I have divided the recovery rates by treatment type. So the blue line is guided self-help, the orange line is well-being, group therapy, and the gray line is Silvercloud Health ICVT. So maybe the first thing that jumps out at you is the fact that all lines are increasing with age. So it is true that that the older age groups seem to be recovering better. But the key thing here is that ICVT and those using Silvercloud, they have high recovery rates across the board, which is actually quite a positive for ICVT in general. But the jump from, say, 55 to 64 to 65 and over is quite big. So look at how the line kind of shifts upwards in those 65 and over into that quite impressive looking number of 85% recovery. Now this is a sample, but it's a large sample, and it just says that in this population, ICVT kind of works wonders really. So that's something important, something to keep in mind. And in terms of reliable recovery, this is another way to visualize it, but we have a similar situation. We have, the gray bar is higher in all age groups, but it's much higher in the 65 and over. So that's where the difference is really pronounced. Okay, so I'll just let that hover for a bit so you can look at the numbers yourself. So yeah, in the younger age groups, they're quite similar, and the difference between ICVT and the more traditional guided self-help becomes to be more pronounced as the age groups increase. So then you see that information, you think, well, then it should be that these older patients should be accessing ICVT much more, but that's not actually the case. So this is now age distribution per intervention, just to see what percentage of patients per intervention fall into each age bracket. And I did it like this so you could see the difference between guided self-help and ICVT and well-being. So look at the blue sections of the pie charts, and you'll notice there's quite a large difference. So in the well-being group, even though in general older patients access IAPT a lot less than their younger counterparts, which we have seen, this gap is much larger in ICVT. So older patients only make up, 65 and over, only make up 1% of the corresponding IAP population, whereas for guided self-help and well-being, it's 8 and 5%. So even though older patients are doing better and they have high recovery rates and they engage more and they use it better, they are not being referred to ICVT because there's still, I think, and this is obviously open for discussion, but some stigma in that older patients may not engage with online programs because they don't understand them as well, or they may, I don't know if it's a matter of having more patience and sitting down with them and showing them the program that may be preventing this them being referred to ICVT, but the data is there, and it's interesting to hear your thoughts on this. So that's kind of the myth around older patients. Yeah.
So I'm desperate to ask a question here. So where are you going to go next with this kind of data then? Because obviously there's something going on where the older adults are doing very well on Silvercloud and in other areas. Are you going to look at the other age groups as well, or because the younger age group does seem to be recovering not as well in all aspects of step 2 intervention?
No, obviously, and that's a good point. I mean, this, even though the focus is on debunking the myth on older age groups, then conversely, if you look at the other end of the graph, younger patients aren't engaging and aren't recovering, and so I think it speaks to both ends that just the conceptions about how you handle ICVT and how you present it to different populations should be modified as per their needs and the way they use it. It's clear they use it in different ways. So we have to engage more also with younger patients.
Okay, yeah, that's very good. Okay.
Right. So anyway, these are direct quotes from older adult users, speaking about reassurance that they could still access it for another 9 months. There is also the aspect of loneliness in this population, and having this available all the time, being able to look at perhaps their journal entries or the things they used or the reviews they got, I think it gives them a sense of security as well. The tailored modules that they could work through at their own pace. This is a sense of independence as well that is sometimes lacking in the care for elderly patients, taking that independence away from them when they clearly still have it and still want it. So I think that's important as well. Anyway, so moving on, let's try and tackle some other myths as well. We still have time.
Yes, yeah, we're getting some questions come in, so please just send them in, and what we'll do is at the end, we'll go through them as quickly as possible. Or what we'll do is we'll email out afterwards when we send this. Obviously, we're recording this and we'll send it out. And if we don't get through all the questions, because there's quite a few coming in now, which is quite good. So we'll crack on with the presentation.
Okay. All right.
Stop interfering.
No, it's fine. You're right. Like, we'll send it out later. So, here, okay, let's look at differences between men and women now. This is actually interesting because in terms of recovery rates, for example, the issue is well, it's not an issue. There is no difference really. The recovery rates are very similar for men and women who use ICVT. You'll see in terms of guided self-help, it's 53, 52. Well-being, it's slightly higher in women. Also, it's worth pointing out that this is another measure of seeing how ICVT is at least has higher recovery rates than the other two therapies. So this I can tell you from looking at the data a lot and from working on at Silvercloud, my experience is that it seems that no matter how you cut the pie, whichever subgroup you want to look at, ICBT is right up there. It usually works better than other therapies at this level. So, I mean, which is great. It's great. And the proportion allocated, the only difference is at well-being. So again, there's a discrepancy here. More men are allocated into well-being group therapy, even though it's women who do a bit better. And so this is in terms of recovery rates, but we have also started to see, right, Doug, that that men are engaging more actually with digital therapy. I think well, you'll continue, but I think the baseline is that men do, I think, find the stigma of walking into, walking into therapy in a center with that label of depression or anxiety has more weight on them, and so that may be a reason why digital therapy is more appealing, right?
So this data set is taken from a standard model where people come into IAP services, are assessed, and then are allocated to the treatment pathway. So one of the interesting things that's happening now, we're being asked to put a front end so people can start their therapy straight away. So obviously they go to the website, they complete the self-referral form, they're then asked, would you like to start straight away? And services are then putting people onto the Silvercloud, and people are then going ahead with that. And one of the things that is beginning to start to emerge is that what we're finding is more men are engaging in that process rather than the traditional through an assessment. One of the things we're hoping to do in the next webinars, we'll have someone from our customer support team come in, and they're going to start looking at the data, and hopefully for the next one we'll be able to show you some of the changes that happen when you put a self sign up at the beginning of a service. So it does seem like men at this moment, when we start digging into the data next time, we'll have much more idea of what it's all about, seem to engage better when they don't have to talk to anyone at the front, which is quite good. So that's for the next webinar.
Great, good plug for the next one. Okay, great. So can we then, let's move on to this one, which is, I think, an interesting one. And this is also something I've heard from, PWPs and therapists and researchers as well, that the assumption is that, the more appointments attended means you'll have a higher chance of recovery. And whilst this is not a complete myth, it's true only to a point. So I want you to look at the recovery rate by number of appointments for ICBT in this population. And clearly, there is an increase 3 to 4 to 5 to 6, and then 7 it kind of levels off, and then 8 and 9 it really so the curve starts to decrease, right? So there is definitely a point of inflection where it doesn't matter if it's 8, 9, 10, 11, 12, 13. You basically reached the highest recovery rate that you can get. So it's not just a matter of the more is better. It's a matter of finding, making the best use of each appointment, because even with 3, 4, 5, or 6, you can achieve recovery. It changes from patient to patient, and with ICBT, this is obviously very important because they are looking at their programs in their own time, and we'll get to that also in a second. They've got access to it all the time, so you don't know how much they're using it between appointments, right? So just this is I think something interesting to keep in mind. Yeah. So then in line with that a little bit is how it's seen. Well, I've also heard that in supported ICBT, after review, that's when patients get the prompt to then log in and look at the review, and that's when they probably mostly log in, right? So they get a review and they log in there and respond, and that's why when they remember about their ICBT and their program, and it's only at specific times of the day when they do so. But this is very far from the truth. So actually, after a review, A quarter of patients log in within the first hour. This is data that we have on the back end of our system. A quarter of our patients log in within the first 6 hours, so that would mean likely the same day, right? But half patients log in thereafter, and that's widely spread out. And it could be the next day, the day after that, within that week, doesn't matter. And also importantly, patients log in at all hours during the day. And yeah.
Can I just say, one of the interesting parts of this is, and then you're going to do this next, is looking at the different programs that we offer. So obviously there's the depression program, there's the anxiety program, there's the comorbid program. Are you going to be looking at these kind of login times depending on the kind of symptomology people presenting with? Because one of the interesting things that we used to experience in the services we had is people with anxiety would get through the program much quicker than people with depression. And it would be interesting to see if the same behaviors are happening.
Yeah, of course. No, of course. I mean, that's the great thing about the data that we're starting to collect, is that because we've got this wide range of programs, like you say, we've got the depression, the anxiety, the space from depression and anxiety, and we've got a wide range of patients, which you'll also see in a minute, patients with different symptomatology profiles. It's not just higher levels of anxiety and lower levels of depression, it's what symptom profile they have of depression and anxiety. Are they more somatic, more cognitive, etc.? And it'll be very interesting to see how these patient types use ICBT and according to the program that they have. So that is definitely some data that will come out in the next few months. And hopefully there'll be a chance to present it in webinars, in conferences, in podcasts. No? So yeah, the one thing I do have here for you now is the login times during the day. So this is a really neat graph showing the login times for a week during the week. So so if you can kind of understand the gray area is, I would say, working hours, no? So 9 to 5, and that's when a lot of people log in, but then you see a spike after 5. So that may mean that patients are coming home, and when they get home during the evening, they're logging in. So there's a spike there, then it drops obviously around midnight. There's seems to be a little increase there right before work. Then there's certain spikes during the day. It's interesting also to note that Monday to Wednesday are the highest. Thursday, Friday, maybe they're thinking of the weekend already, and instead of going home, they're going to the pub or someplace else. But the fact remains that they're logging in all the time. I mean, these are the number of patients logging in all the time, and on the weekend, then it's spread out during the day. So there is,
The bit I was surprised about, having run at IAP services, is the Sunday. Because when we used to try and run appointments at the weekend, it was very low. And it is surprising that the Sunday peak is higher than the Saturday peak. That would be fascinating, again, to look at what kind of presentation that is, what's going on. I know I get the Sunday blues, so maybe that's the type of thing going on. I don't really want to go back to work on a Monday.
No, that's very true. So yeah, that's things. Those are things to look into further. But at the very least, we can see that there is a positive in this offering of 24/7, because depending on the patient, they will log in at different times, right? So we've got 5 minutes. So this is just the last one. We are talking mostly about step 2. This example that I showed you is at the step 2 level, which means mild to moderate anxiety and depression. And the myth here is that then ICBT, because it was built initially for these patients, works mainly for patients in the spectrum. But in fact, it does tackle, and it decreases. So it tackles all spectrums, right? So from severe to moderately severe down to mild moderate, and you'll see this in these couple of graphs. So this is data. The N is much higher because this is actually data from across our services that we have. So this is 40,000 patients that we're looking at, which is a huge number, and the distribution of severity you see, from pre to post is there is quite a large distribution of severe and moderately severe according to the PHQ-9 and GAD. And yet, all of so the red decreases quite a bit, the orange decreases quite a bit. And what increases is the mild and minimal groups, right? Because that means that patients across the spectrum are decreasing their symptoms. So that's great to see that. In fact, it's not just for people with mild to moderate symptoms, but people with severe symptoms can also take something out of it. And this is about behavior change. It's about, it's about learning, understanding that there's different modules that, patients will use depending on their needs. And this is, again, something that we will look further into depending on the program types and symptom profiles that we have.
And it's quite interesting because the question has come in about this, and I think this seems quite apt to do this now, is that talking about Silvercloud being used at step 3, and clearly it does look like people are using it at step 3. Are we able to discern to a certain extent whether someone is being seen at step 3 or step 2? Is that something that we can look at in the future just to see the impact? Some people said it helps reduce the number of face-to-face appointments because people get the language, they get some of the key themes and tools that you use. Is that something that we can look at?
Yeah, and even reducing the, for those people on the waiting list for step 3, tackling it there so they never go up. Sorry, I was still covering that. But yeah, that's something we can look at in the future, and that's something we need to, because that's very important for service provision and something that's obviously going to be of interest to people working on step 2 and step 3.
And one of the interesting things for me is about the kind of who's suitable for CBT. And the traditional way that's always been done is to do it by GAD and PHQ, but here it seems to show that it's not necessarily the presentation, the symptomology that people have, it's actually whether they're going to engage with it. And maybe we need to think about measures of engagement, questions we can ask people early on to see whether they're going to be suitable or not.
Yeah, and that's actually the hot topic in conferences and research conferences, like adherence. I mean, we need to think about adherence. Yes. A lot of people have shown that it works. We're not the only ones. I do think we have, an incredibly good product, and when you can put it up against any other. But everyone talks about increasing adherence, and that's something that we're actually looking at as well. We are. I'm working on a paper with another colleague to use this back-end data that we have on adherence measures and see which ones are actually the most valuable.
Yeah.
So, is it the page views? Is it the logins? Is it the average time per session? Is it the journal entries? What parts of the program can tell us most about how much patients are adhering? And there's there's an ideal in the research world and in the clinical world of like having recommended adherence. So to actually find that, the key level that you have to reach to get someone to adhere to an ICBT, a minimal, it's like giving a minimal dose of take paracetamol. And if you take it for 3 days, your fever will go down. Well, we can hopefully in the future say, log in for this amount, use this amount of the program, and then you'll likely recover, right?
That's quite powerful. And do we have time? We're going to run out of time as we thought we might do when we chat together. But there are a couple of questions that I could give you at this moment. One of the questions was for the older adult group. What was the size of the sample?
The size of the
original.
Oh yeah, for the whole 2000. So yeah, it was the sample size was I can't remember the exact number, but it was around for the 65 and over, about 250, 300.
So it's quite well, when we're talking about 40,000 people, 200 is quite small, but that's still quite a big sample size.
Yeah, it's just, they're the least, obviously they're the smallest group. So, but the more data we have, the more data we'll have on 65-year-olds as well.
And the overall numbers coming into WAP still around about 7 to 8%. So that's kind of about the same size.
Yeah.
And then there was another question for the self-sign-up page about how risk is managed. And obviously for the next webinar, what I'm going to do is try and bring in a whole session on that. But what we do, because obviously Silvercloud is able to capture the scores and capture the risk assessment in there. So a lot of services are setting up the self sign up as a set of questionnaires, PHP GAD, and obviously if people are triggering PHP 9, then they'll be given a really polite email saying you're not suitable. Well, not that you're not suitable. I'm never going to do it. It's saying how to do this in the most polite way, but is that we thank you for your interest. The service will contact you immediately, and we work very closely with IF services, so our risk process is quite clear. An email goes to people, and then obviously you then are able to bring the person up and make sure they're okay. So hopefully that will help with that. And then if there are any more questions that people have, if you want to put them through now, I think that's covered most of it. There's also someone's made a comment that what they do is they use Silvercloud as a relapse prevention plan. And quite interestingly is that we've noticed this as well, and we were about to launch a resilience program, which we think might help with that even more and help people with that transition out the service. And hopefully some of you might be interested in trialing that and talking to our team about making that available. Now, I'm just going to quickly check through the questions. Okay, also use of counsellors of extra. So yeah, so obviously one of the nice things about the way that the Silvercloud program works is you can unlock modules for people. One of the favourite ones for that has always been the sleep module. And again, we're going to be releasing sleep as a standalone module in the next couple of weeks as well. So again, hopefully that will be something that you guys will be interested in looking at, and hopefully your the clients will like that as well. So as I'm meant to keep to the 30 minutes, I'd just like to thank Jorge again for a very interesting. I always find it fascinating doing this, and hopefully he'll be back again at some point with some further data, and we'll hopefully have that again. Just to say to you all.
Yeah, promise.
You promised.
Yeah, and thanks everyone for joining as well.
Okay, so thank you all very much, and hopefully we'll speak to you all again in a couple of months. Thank you.